Okay, I think we'll start. My name is Michael Reich. I'm a faculty member in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health, and I'll be moderating the seminar today. It's a pleasure for me to introduce Professor Aya Goto, who will be speaking with us today about health literacy promotion as a key in long-term responses after the Fukushima nuclear disaster in 2011. Dr. Goto is professor of health information and epidemiology at the Fukushima Medical University in Fukushima, Japan. She also serves as professor of international community health in the Graduate School of Medicine at the same university, and the deputy chief of the Fukushima Health Management Survey with a focus on pregnancy and birth survey, also at Fukushima Medical University. She also directs JICA's, which is Japan's International Cooperation Agency's evidence-based medicine promotion program in Vietnam. Her main research interests are reproductive health, parenting support, community health, and health literacy. Her translational research has been conducted in close collaboration with local communities, both in Fukushima and in Ho Chi Minh City in Vietnam. Since the Fukushima nuclear disaster in 2011, Dr. Goto has been working closely with local public health nurses in the city of Fukushima to help them respond appropriately to the concerns of parents of small children about elevated background radiation. She has her MPH from the Harvard Chan School and is also a former Takumi Fellow in International Health. She's joining us from Japan, where it is 2 a.m. in the morning. She said she's lucky that she's speaking during the talk just so that she doesn't fall asleep. It's a great pleasure for me to introduce her. Please, you can put questions and comments in the chat, but hold your questions until the end. You can raise your hand physically or else your electronic hand. And again, the title of the talk is Health Literacy Promotion as a Key in Long-Term Responses after the Fukushima nuclear disaster in 2011. I should note, Aya lives in Fukushima and has a son and has lived through the disaster and the response in her own family and in a personal way. So it's, again, thank you so much for joining us. And Aya.
Hey, thank you very much for a nice, concise introduction, Professor Michael, Professor Reich. It is my great honor that Professor Reich is moderating my talk, and he has been supervising my work for over 20 years, I guess, since I was an MPH student. And I would like to thank everyone for giving me this opportunity to talk about my work, how it evolved after the Fukushima nuclear disaster in 2011. Well, let me share my screen. Okay, here it is. Okay. So first of all, Professor Reich kindly introduced me, but let me explain in my own way about my background. I am an obstetrician gynecologist by training and currently work as a public health doctor in Japan and also in Vietnam. As a clinical doctor, I had direct contact with individual patients. But as a public health doctor, I no longer touch patients. I do community diagnosis and treatment. And this picture on the right, taken in Vietnam, symbolizes what I do. A midwife is interviewing a pregnant woman while I check records of all pregnant women in the village to diagnose the whole community. In Japan, public health doctors like myself work with public health nurses to diagnose the community using data like health statistics and survey data. And as treatment, we prescribe health policy and health promotion activities. So the health information is one of the medication we prescribe utilizing community resources. The balance between doctors and nurses in Japan is very different among different fields. The number of doctors and nurses is 1 versus 4 in general, but in public health, it is 1 versus 17. So the main actors are the nurses. They're the ones who provide health and parenting counseling. And in the picture on the right, I am planning health promotion activities with public health nurses. It is very interesting that in Japanese health system that this public health nursing system was established in 1941, well before when the UHC was established in Japan in 1961. And today I will begin with how I started my work on health literacy and introduce its concept. Then I will explain our capacity building activities for professionals and also children in the community. Furthermore, I will explain how our expertise developed after the Fukushima nuclear disaster helped us work for children when facing a new crisis, which was COVID-19 pandemic. Well, before 2011, when the nuclear disaster happened, I was happily doing research and community work, for example, importing parenting support programs from Australia and Canada into Japanese public health setting in order to prevent postpartum depression and to promote positive parenting. But 12 years ago, suddenly I felt a big shake, which I never experienced before. Water and electricity stopped for about a week. During that time, we heard about the explosion of the nuclear power station in the coastline. Since then, my work largely changed. Fukushima City, where our university is located, was within the initial US recommended evacuation zone. So naturally, parents especially were worried, and we observed about 15% decline in under 5 years old population in the initial 2 years. And this fear of unknown health effects of radiation contamination was due in part to confusing and often contradicting health risk messages with difficult scientific data. This little picture on the left shows many leaflets about radiation placed in the lobby of a health center in Fukushima City. It is clear even from this small picture that they contain many sentences, numbers, and charts that are difficult to understand. That was difficult for me to understand. So personally, I was wondering whether to stay or to move, just like other mothers. After learning about radiation exposure, its health effects, and about the situation in Fukushima City, I showed my son a map of Japan. It was a week or so after the disaster. He was 6 years old. I showed him where we lived, where our relatives were, and where the explosion happened. Then I asked him where he wanted to live. And he said, "Mom, if you think it is safe here, I am a Fukushima boy. All my friends are here. I want to stay." So, and then we decided to stay. And this was truly when I truly learned and understood the social capital of a child. And by the way, this picture was taken, maybe some of you have noticed, but was taken at the Children's Museum in Boston. I was a Takemi Fellow from 2012 to 13. And it was a wonderful time for me to live in a different culture with my family and to concentrate on analyzing data which I brought from Fukushima City and think in depth how I could contribute to the community. And this is work that I did when I was a Takemi Fellow. Right after the nuclear disaster, I collected and analyzed child health checkup data with public health nurses in fields. Interestingly, we found that mothers who were worried with differences in risk perception among family members were more depressed. So I thought, why? And we analyzed handwritten records of parenting counseling in order to understand what really was happening at home. We scanned the notes, entered into computer, and analyzed. Notes mean notes from the child health checkup files. And one nurse wrote that mother is worried about radiation and cannot let child play outside. Father says it is all right. So here you can see a little daily activity like letting a child play outside became a source of parental conflict. And around the time that we collected this data in 2012, people were digging out schoolyards to replace surface soil in order to reduce external exposure among children. And children, they were starting to learn about radiation. And these are the pictures I took at my son's school and Children's Museum in Fukushima City. The boy in red in the little picture is my son learning to read the dosimeter. And around the same time, I started organizing meetings with the nurses and analyzed their discussion notes. I found that they recognized their roles as an information channel in the community, and they needed communication skills development. One nurse wrote that we must say what we think about what we have learned, not just what the government says. So nurses, they needed to not only to understand the difficult scientific data, but also to be able to explain in their own words that are understandable to people. This is difficult. And here, so mothers were confused about the information provided and nurses needed communication skills development. And here I came to learn the key concept, that health literacy, when I was a Takemi Fellow. It is defined as people's ability to understand and use health information to improve health. And recently, this definition was expanded to include health professional skills to improve people's access to information. This is clearly shown in the US Healthy People 2030 as the organizational health literacy. Health professionals as a team should equitably enable people to use health information. And another new concept in health literacy is e-health literacy. It is people's ability to use digital information. We have found that people's e-health literacy level is associated with their actual usage of digital tools, of course. And this tells that we should support those with low e-health literacy level to better use digital information so no one will be left behind. But let's go back to the two arcs of health literacy. First of all, I studied a project to increase health professionals' skills. I adopted the US health literacy training model to the Japanese language and context. This model project was developed by Dr. Rima Rudd at Harvard. There are three components. Firstly, we teach how to assess the understandability of health information. Second, we teach how to improve the information, followed by field practice of the learned skills. The whole workshop takes about 2 to 3 hours. We teach skills to improve sentences, graphics, and ways to understand intended audience, the information, and health literacy needs. On the right-hand side is a little booklet I developed and use in teaching. Okay, these are the pictures from my health literacy workshops. You see, they are mostly public health nurses, and they do exercises, they do presentations, and they're laughing, and it's a lot of fun. And let me here do a little exercise with you. This is an introductory exercise that I usually do in the beginning of my health literacy workshop. Okay, so one day when I was waiting for my husband's car in the lobby of my apartment building, I was looking at the front door, which was automatic door. And then I thought, oh, health literacy wise, this automatic door is very, very nice. Can you tell why? So I said health literacy wise. So the door contains health information. And I thought the way these are presented was very nice. Can I have some volunteer to respond to my questions? Or if there is no one, then Michael maybe can give a try.
So this is an opportunity for people to participate. You can either turn on your camera or not, but turn your microphone on. What are the communications elements that you see in this picture?
Maybe the information is too small, so I can zoom on the part that I'm focusing on. These are the part is here.
You don't need to understand Japanese.
No. There are a number of information shown on the picture. Do you see anything, Professor Reich?
So first of all, I see the triangles, which presumably say, be careful, warning.
Good.
And then I see the symbol of the hand, which presumably means don't touch the door. And then I see the two arrows, which probably means when you get close, the door is going to open in that direction.
Wonderful. Yes. So you have spotted all the health information pieces that I wanted to explain. But then my next question is, what are the differences you see between the yellow triangle and the red mark? Well, you don't need to come close. You can tell from this.
Okay, so can I volunteer? One of this, the yellow presumably is a caution, and the red is a ban. So the yellow says be aware of, and the red says don't.
Now, Dan, why do you think, what about the location of the signs?
I guess that's how they do things in Japan. No, I, I don't know. Good question.
So the red
But
ones,
maybe the caution is more important because no, that didn't right. I don't know the answer. Good question.
I don't know the answer either.
well, you two are coming very close to my answer. So the red one tells don't. To whom?
To someone who doesn't know that already, namely
To whom someone who doesn't
lay person.
Kids in child, it's for children. It's at a
Yes.
lower level.
Yes,
Right,
thank
right.
you. Yes, that was my point. So the red marks, thank you very much for your participation. So the red marks were for children. And what I want to tell people with this little exercise is that health literacy perspective, you need to understand the audience, your patient's view. So for children, you have to come low and make eye contact at the children's level. So health literacy is not just about writing easy to understand sentences and numbers, but it's about understanding your clients and your audience. And I continue exercises like this using many pictures. And for example, the next exercise, I will not take too much time on this today, but these are the pictures taken from a hospital in Japan. And I let my participants think health literacy wise, what are good? Just like you did with the automatic door exercise. Okay, so the evaluation of this health literacy workshop, by 2019, about 25% of the nurses in Fukushima had attended the workshop. In total, there are about 700 to 800 nurses. Nearly half of the attendants use the learned skills in practice at the 1 month follow-up and even more at the 1 month follow-up, 1 year follow-up. For example, a nurse wrote, by using the learned skills, I was able to clearly communicate my points and facilitate the exercise session smoothly. And this tells that the health literacy training led to a service improvement. And we also found that trained nurses had more positive attitude for feedback from the community residents. They were 2 times more satisfied with the feedback from the community on their activities. And their self-evaluation of risk communication competencies improved. These competencies included responding to residents' concerns, alleviating their distress and building trust. Moreover, an assessment among this is important, I think, assessment among the intended audience showed that older people and those without regular doctor visits more likely to notice the improvements in health information be biased by the trained nurses. So the health literacy capacity building would contribute to improving health services, promoting communication between professionals, and preventing inequity in access to health information. And I keep getting requests to run this workshop for different groups. Professionals include nutritionists, school administrators, disaster prevention officers, and so on. And at universities, I teach health literacy to medical and nursing students. And this year I'm teaching at 8 schools. I also give workshops for international students and JICA trainees. And so this health literacy training is crossing borders. Well, here is a case after the pandemic. So prefecture office of site Fukushima invited me to give an online workshop. Participants were mostly nurses and administrators. And over 80% answered that learned skills could be applied immediately at work. A participant wrote that the learned skills could be applied in supporting COVID-19 patients. I will share the skills with my colleagues. Another one wrote about being assured of the importance of residents' point of view. So these indicate that learning health literacy perspective and skills empowers crisis responders and improves their teamwork and resident-centered care. Secondly, I moved on to plan and implement a project to increase community residents' skills. WHO states that health literacy is important in the empowerment of people. So health literacy is more than just, as I said already, making easy to understand information. Here's my recent paper explaining very simply the 3 points of communicating with the public. The third point, that a participatory approach is important in crisis. In my current work, I collaborate with school children. The school health project called Creative Health has 3 components. First, we developed the ACT workshop in blue in the middle, which applied the performance-based method adopted from the UK in order to withdraw children's opinions through making and acting short dramas about the place they live. ACT means performing and also being an active citizen in community. And we then added the topic-based body and food workshops. And these are the pictures from the ACT workshop. You can see children on the left discussing what they like in their community and planning their performance. And on the right, they are showing their performances to each other. In the food workshop, before COVID, we planned to do cooking classes, but we couldn't during the pandemic. So instead, we did quizzes and cooking demonstration, and children enjoyed tasting. And they did also some drawing, and based on the data, that data meaning drawings, a medical student in my team did quantitative, this was interesting, quantitative analysis of the drawings. And we found out that we were able to extract children's view of their foods in their community through these drawings. And these are from body workshop. For example, we asked them to measure their pulse and create a histogram. And so our activities aim to facilitate, you can see from these pictures, students' scientific thinking and creative thinking and working in teams, presenting and expressing their opinions. The evolution of the evaluation of the project at 2 schools in Fukushima showed that children appreciated these collaborative and creative activities and perceived their health and community more positively after participating. Well, our initial plan was to expand the project to Indonesia, Cambodia, and Rwanda, but then the pandemic started. So we could not travel, so we did online training for facilitators. The picture shows our online training of the ACT workshop for Indonesian facilitators. The workshop was immediately implemented at Indonesian schools in collaboration with university students. Children enjoyed and parents were happy about their children's learning. Importantly, I think school teachers learn to accept students' opinions and recognize their abilities. And in Japan, when the pandemic started, based on our existing network with local school teachers through Creative Health, we developed written materials for children. These are materials for infection prevention and self-learning materials for to do little adventures at home. And the materials were distributed to children and families as handouts when they could come to school, and also through school websites. And through the Takemi program global network, Professor Reich introduced me a Takemi fellow doing a very similar work in Madagascar. So we compared our cases. We had research meetings online, and we identified 3 common communication strategies. First, develop culturally tailored and visually appealing materials. Second, disseminate through existing channels in a timely manner. Third, our experiences emphasized on the importance of collaborating efforts based on an existing trust relationship. And actually in my health literacy classes for medical and nursing students, I used this example as an exercise. I let students compare 2 leaflets and discuss common and different points. Well, this is my last slide. In summary, the evolution of our health literacy initiatives covers 2 arcs of health literacy. It's crossing borders and prepares us to face a new crisis through existing trust relationships and by utilizing digital tools. Thank you very much for listening.
Thank you very much, Dr. Goto. And again, my apologies for the interruptions during the talk. So we have about 25 minutes for questions and comments. And the floor is open. You can either raise your hand and unmute yourself. You're welcome to turn on your camera. So maybe I'll start. So have you done, you spoke a lot about health literacy programs for nurses. Dr. Goto, I wonder, have you done health literacy programs for medical doctors?
Good points. Yeah. Initially, they were less interested in the workshops that I was doing, but gradually they heard how it was interesting from the nurses, and yes, some of them participated.
And have you done, I'm wondering if you've done health literacy programs for your colleagues at the School of Public Health, and what you see about the role of training people in health literacy in public health more broadly.
Yes, that is a good point. Yes, at my university, I have given health literacy workshops multiple times, and I teach to medical and nursing students. And I've seen that some actually doctors became strong advocates of health literacy, but at the same time, they encountered conflict with their colleagues, because from health literacy perspective and the knowledge that they gained through the workshop, they thought the information, they understood very well how the information they're creating, for example, about the Fukushima Health Management Survey, needs to be formed in a very easy way for people to understand. But some of the colleagues says, no, this is not our culture. This is not the way that we present our data. So that's why I think that organizational health literacy becomes very, very important. And they need to work as a team.
Good, thank you. Dan?
First of all, thank you very much for this presentation. It's fascinating, both for your work in health literacy and also to learn about the nurses, public health nurses, which is really remarkable. And then, of course, the fascination with the power plant disaster. It's just amazing. Now, so I'm going to ask you a question that doesn't relate to that, though, and so I'm just going to sort of abuse my opportunity here to ask you. I've long been interested in the use of pictures and other visual aids to engage to people who are scientifically illiterate or maybe completely illiterate. For example, when you're recruiting people into research projects and you need to get informed consent. And I'm corresponding with a colleague of mine in Azerbaijan who is he's actually a very able artist, so he's trying to figure out how to draw the pictures. So we did this, and the stumbling blocks for us are the ones that involve concepts like randomization and objectivity and trying to warn someone. This is a real difficult one. The one problem we have is the so-called therapeutic misconception when you approach somebody and they think you have medical stuff on and they think you're their doctor, but actually you're not. You're using them as a guinea pig, and you have to dispel that misconception, or else they're entering under false. All right, now so you can see these concepts are rather abstract, and we can't figure out how you can communicate those with pictures. Have you ever tried this, and do you have any experience that you might offer us? And also, can I have your PowerPoint?
Sure. Yes, you can have your my PowerPoint, of course, and yes, I have encountered such a case that you just described. For example, for a prefecture-wide cohort survey called Fukushima Health Management Survey that includes thyroid cancer screening among children, and people are observing a rapid increase in the occurrence of thyroid cancer among children. And this is due mostly in part to screening effect. But this is a very abstract concept for people to understand. So some people are believing that we are really having this increase of a cancer among children. And for this particular case, working with the Ministry of the Environment, we created a little diagram to explain to people about the screening effect in a little, just one figure, and which was came in very handy. And like this, so basically we used a pictogram. And pictogram, people are very familiar with that in Japan. So that is very well understood among people and the culture in Japan. But I think the case would be different. What will be better understood among people would be different in different countries and different settings, I think. And also in my health literacy workshop, instead of using charts, tables, and graphs, I recommend health professionals to use pictograms and infographics. I hope that answers to your question.
It does. I have several follow-up questions, but I'll write to you about it.
My suggestion, Dan, is that you contact Dr. Goto, and I'm sure that, I mean, it'd be interesting to take some of the concepts that come out of bioethics and translate them into pictograms.
Listen, if you can do that, you get a Nobel Prize.
Right. Well,
we actually reached out to one of the world's leading practitioners of informational graphics. He's a Dutchman who does the signage for airports and so on. He's marvelous, and we brought him to Harvard and talked to him for. In the end, he told us that we're going to fail. He said because any pictograph that you might come up with that could possibly explain things like you're just talking about would be indecipherable to anybody except relatively sophisticated readers, preferably ones who are used to pictographs like the Japanese public has become. So he said the hope that you can go to a place where people are actually illiterate and have never seen a pictograph and come up with a picture that could explain randomization or conflict of interest or whatever to them. He said, forget it. And so we gave up.
Well, I think this would be a great topic for additional research, even starting with the idea of conflict of interest. And because certainly that idea does exist in different ways in different societies and cultures. Shekhar, you had a question?
Yes, thank you, Michael, and thank you, Dr. Goto, for a very, very interesting presentation. My question is about public education and awareness on mental health. And I noticed that you have worked earlier on postpartum depression. And so the question is, do you find some additional barriers or difficulties in conveying public awareness and education on mental health versus other areas of work that you have done? Because I have struggled with this for a long time, and some of the messages can be a little bit more complex. And I just want to know what your experience has been in that area, if at all.
Thank you for your very important question, because after the Fukushima nuclear disaster, we observed an increase in postpartum depression. So that was a very important topic for us. But for us, we were lucky because 10 years ago, when the nuclear power plant accident happened, people, mothers and people knew well about the word postpartum depression and mental health disorders after pregnancy. Even though pregnancy is a happy event, it can be very stressful for the couples to adjust to a new environment. And this topic was well talked about in community. So we didn't encounter any difficulty attached because of the stigma attached to mental health issues, especially in maternal and child health. But the practical, when it comes to practical support that we had to provide to mothers, that was a little bit difficult. We prepared online email counseling system and telephone counseling system. And also we had personal public health nurses supporting community. So we had to establish this comprehensive support after the disaster happened.
Thank you.
Good. Are there any other questions? Jackie, Aisha, from any of the other people on the call? Dan?
Since we have a moment, can I ask you whether you found in the wake of the disaster that was there deep distrust of government and of the power plant company TEPCO, and was this something that you had to address in your public health? I mean, did that extend to you as did they think, oh, here comes another person from the power elite or whatever it is who's telling us what to think? And if they I mean, I'm curious whether they did distrust, whether there was distrust, and if there was, whether you had to deal with it, and if so, how you did.
Yes, there were certain groups of people who had very strong distrust toward government. And also, even the researchers at Fukushima Medical Universities, we were considered as standing on the side of the government. So many people didn't like us. When we did the cohort survey to monitor people's health, they resisted by the people in the community resisted by saying, some of them thanked us actually, but many of them resisted us by saying, well, are you treating us as experimental mice? So it was a very difficult issue for us to face. And first, I think many of us tried to solve the problem, seeing this as a problem and try to solve the problem. But after a long time, we came to accept the fact, the different views that people have, the strong distrust when it intervenes with a provision of services, that would be a problem. But we need to start accept people's different views, and that's where we can start our conversation. That's what how we were thinking right now.
Good.
Well, if I can ask just one follow-up, and don't answer if this is too personal, but were there ever occasions where you had skepticism about what was coming out of the government or the company, and you thought you could be a resource to the people there to tell them what you thought the truth was and to alert them to the fact that they're being lied to?
Yes, I encountered these cases, and it was good for me that I was a mother living in the region, and also I was a professional. So people, when I was talking with especially mothers, they trusted me. That was good. Even though they didn't like my university, they trusted me. That was good. And this distrust is continuing. And when I am, even now, when I am implementing the creative health workshops at schools in Fukushima, even some teachers, they don't like us coming. But I just need to continue doing what I believe that is good for the community.
Yeah, it's difficult.
So one of the things that's striking, Aya, about your presentation is the way in which you have combined both your personal story and who you are as a person with your professional story and the work that you've been doing. And, and I think it's an interesting comment on the role of public health professionals about how we relate to what goes on around us, and not just relate to it, but bring our professional skills, expertise, and new ideas to the public health events happening in our communities. And I wonder if you could just talk a little bit about why you did that and whether you ever felt sometimes reluctance.
Very good question. I often receive questions like that from people after presenting, and my usual answer is that I don't feel reluctant, and I never felt reluctant in doing things that I have been doing, because basically I only do things that based on communicating with the people in the community, and what they told me what they needed. I simply responded to their request, adding a little bit of professional skills and knowledge.
And how has it affected your own development and the ideas that, I mean, you didn't start out doing health literacy.
I did not start out doing health literacy. It was what the public health nurses needed, and then it was, and then it was around the time that I came to Harvard as a Takemi Fellow. And Michael, you introduced me the Professor Dr. Rima Rad, and then I started learning health literacy. So basically, I just followed the way that I thought that I needed to go.
Good. Thank you very much. So anyone else with a comment or question? Okay, if not, I think we'll end a few minutes early. Again, my apologies for the interruptions. Thank you so much for your responses, for the presentation in the middle of the night at 2 o'clock in the morning in Japan. Thank you very much, Aya.
Thank you very much. I enjoyed it very much.
And
Thank you.
thank you everyone for participating.